Dry needling and acupuncture use the same type of needle, but that is roughly where the similarity ends. Understanding the genuine differences helps you make a better informed decision about whether either is appropriate for your condition and what to expect if your physiotherapist recommends one. Acupuncture has a history of more than 3,000 years within traditional Chinese medicine. The original theoretical framework involves vital energy, qi, flowing through channels called meridians, and needles are placed at specific points to correct imbalances understood to produce illness and pain. Modern research shows that acupuncture needle insertion produces real, measurable physiological effects, local tissue responses, endorphin release, and modulation of central pain processing through the descending inhibitory system. These effects are clinically meaningful regardless of which explanatory framework you apply to them. The evidence base for acupuncture is relatively strong for chronic pain conditions, neck pain, lower back pain, osteoarthritis-related pain, and tension-type headaches all have multiple high-quality trials supporting its use as an effective adjunct. Dry needling emerged as a separate Western clinical technique in the late 1970s through the work of Travell and Simons, the researchers who mapped myofascial trigger points. A trigger point is a hypersensitive nodule within a taut muscle band that produces both local pain and characteristic referred pain at a distance. The mechanism of dry needling is anatomically specific. The needle is inserted directly into the trigger point to provoke a local twitch response, a brief involuntary muscle cramp that mechanically disrupts the taut band and normalizes the abnormal electrical activity of the muscle spindle within it. That local twitch is the therapeutic event the technique is designed to produce. You feel it as a brief sharp cramp at the needle site, lasting 1 to 2 seconds before resolving. If no local twitch is produced, the needle has not engaged the trigger point and the practitioner will redirect. The evidence for dry needling is strongest for myofascial pain syndrome with identifiable active trigger points, and for the trigger point component of conditions including chronic neck pain, shoulder impingement, and lower back pain involving the quadratus lumborum. It is most useful when manual trigger point release has produced only temporary change and more direct mechanical stimulation of the taut band is required. Acupuncture is the more appropriate choice when central sensitization is a significant component of the pain, where the nervous system has become globally upregulated and amplifying normal signals into disproportionate pain. In those cases, acupuncture's effects on central pain modulatory systems can meaningfully reduce the amplification that exercise rehabilitation alone addresses slowly. Central sensitization is more common in chronic pain presentations, pain present for more than 3 months, and in people with widespread pain, poor sleep, and high sustained stress, all of which amplify the nervous system's sensitivity to normal inputs and make loading-based rehabilitation harder to tolerate initially. In Malaysia, dry needling is predominantly performed by physiotherapists who have completed postgraduate certification in the technique. Acupuncture is practiced by TCM practitioners with multi-year degree training, and also by physiotherapists and other allied health professionals with recognized postgraduate acupuncture qualifications. If you are unsure of a practitioner's qualifications, ask specifically what training they completed and whether they are registered with the relevant professional body. Both Malaysian Physiotherapy Association members and TCM practitioners should be able to answer this clearly. A practical distinction. If you receive dry needling as part of a physiotherapy session, it will be integrated with exercise rehabilitation within the same appointment. If you receive acupuncture from a TCM practitioner, it may be the standalone modality offered. The most important thing both approaches share is that neither produces lasting structural change on its own. Both reduce pain and muscle tension to a degree that improves the quality of the movement therapy that drives structural recovery. A practitioner offering either technique without concurrent exercise-based rehabilitation is not providing a complete program. Ask at your first appointment how many of your treatment sessions will include exercise prescription. If the answer is none, that is a clear signal to look for a provider whose approach is more comprehensive. The link in the description provides a full clinical breakdown of both techniques and what to expect if your physiotherapist recommends either for your condition.